Welcome to Module 5, focused on Pain Assessment, Advanced 2. The objectives for this module are to describe recommendations for pain assessment in cognitively impaired older adults, specifically looking at behavior and tool selection, to discuss challenges of pain assessment in this population, and to describe 2 pain behavior assessment tools that can be used with residents who are unable to self-report. What do we know about the pain experience of older adults with dementia? A lot of research has been going on in this area to help us to understand the experience of pain in people with dementia. And what we know is that individuals with dementia experience the same type of painful conditions as those who are cognitively intact, and they perceive the same painful stimulus the same. The difference is in how they interpret that painful stimulus in the brain, which is reflected by the level of dementia that they're experiencing. But given that they experience the pain sensation, and pain is common in those with dementia, it's best to assume that pain is present in the same conditions as those who can tell us that they're hurting and experiencing pain. The American Society for Pain Management Nursing has recently published an updated position statement about assessment of pain in persons unable to self-report, which speaks specifically to those who are cognitively impaired with dementia. The position statement states that all people deserve prompt recognition and treatment, that pain should be routinely assessed, reassessed, and documented to facilitate treatment and communication across clinicians, and importantly, that there is no single objective assessment strategy, such as interpretation of behaviors, looking at pathology, or looking at estimates of pain by others, that is sufficient by itself. It takes a combination of sources of information to identify pain in those that are cognitively impaired and unable to communicate their pain directly. General recommendations for assessment of pain in those who are cognitively impaired focus on, first, looking at the resident's history, what information is in their medical record, interviewing them about their pain experience if they can communicate, and looking at results of physical examination, seeking information about possible conditions or diagnoses that we know are painful in those who are cognitively intact, because we need to consider these painful in those who can't communicate to us as well. It's important to use assessment approaches that include both self-report and observational measures when possible. Many people with dementia and mild to moderate cognitive impairment can self-report and can at least indicate if they're experiencing pain, even if they can't rate how severe it is. This should be a gold standard and part of our assessment approach. It's also important to conduct pain assessments during movement, such as during transferring, bathing, dressing, ambulating. We've learned that if we assess for pain when patients are at rest, we may miss a painful condition because the behaviors that occur on movement are not present. And in dementia, it's important to use resources such as individuals that know the resident well, the CNA, the housekeeper who may spend a lot of time with them, family members, to help to identify typical pain behaviors for that person, because there is often a unique pattern that's variable from resident to resident. So what are some of the challenges in assessing pain in the cognitively impaired? Well, we know that their ability to communicate pain can be impacted. Self-report is often not possible or unreliable. So this creates a challenge for us, and it does lead us to look at a variety of different sources of information to identify possible pain problems. We do know that people with dementia experience pain sensation to a degree similar to those that can communicate with us, so we have to move forward as if those with painful diagnoses or conditions that can't tell us what they're experiencing are experiencing pain until proven otherwise. We also know that vital sign changes are not accurate in reflecting pain changes, particularly acute pain changes in people with dementia, so they should not be relied on. And we also know that pain can negatively affect cognitive function. So changes in mental status may be related to medications the patient's receiving, but it also could be a reflection of unrecognized or undertreated pain. Part of the process to address issues in pain assessment with cognitively impaired are to go through the process of searching for potential causes of pain, observing the patient for behaviors that might be pain-related, and using behavioral pain assessment tools to help us to capture indicators of pain consistently and to be able to communicate across provider and across shift in an effective manner. The American Society for Pain Management Nursing recently published a position statement on pain assessment in persons that are unable to self-report, and this involved recommendations related to the importance of establishing a pain assessment procedure, and this needs to be done in the nursing home facility as well. Use of a hierarchy for pain assessment techniques. This hierarchy focuses on first trying to get self-report, second, looking for painful diagnoses and conditions, third, looking and observing for behaviors that might be pain-related, fourth, seeking surrogate or proxy input and report of pain, and 5, using an analgesic trial as a way of trying to validate if behaviors that we see and think are pain-related by their response to an analgesic treatment. Another recommendation is to assume that pain is present when there are diagnoses or conditions that we know are painful. Fourth, use behavior assessment tools as a way of monitoring and evaluating pain over time. And reassessment and documenting what we find and what indicators are pain-related so that others are able to follow up and assess accurately for change are part of the recommendations of this task force. When should pain be assessed? Well, when pain should be assessed is no different for those that have cognitive impairment as compared to the residents that are intact and can self-report. The timing of assessments is the same. So every resident should be assessed for pain at admission, anytime there's a change in their status, anytime pain is suspected, and at least quarterly. How do we select tools for assessing pain in those with cognitive impairment? Well, studies have shown that many older people with mild to moderate cognitive impairment are able to use simple pain scales. Numeric rating scales, including those that are just a 0 to 3, with 0 being none and mild, moderate, severe, is a very simple numeric rating system, or use of word scales that could be used in this population. A pain thermometer has been shown to be helpful because it shows pain increasing as temperature rises, and it helps with abstract thinking and in tracking what we're asking for. Use of words is a preferred approach by most older people and seems to be easiest for those with cognitive impairment. For those with severe cognitive impairment who are not able to self-report or use a scale to report their pain, there are many tools that have been developed to assess and recognize pain behaviors. There are 2 that have been recommended recently for use in nursing homes because of their ease of use, their established reliability and validity, and their integration into systems within the nursing home environment. And that's the PAIN-ADD, the Pain Assessment in Advanced Dementia, and the PACSLAC, which is the Pain Assessment Checklist for seniors with limited ability to communicate. These tools could be used at different times for different purposes. The PAIN-ADD is a very short tool, and the PACSLAC is a little bit longer and more comprehensive, but we'll be talking about these in more detail to follow. Some things to consider in tool selection is that we need to determine the ability of the resident and use an individualized approach then in getting baseline scores. So if they can use a self-report tool, that should be done and identify the one that they understand, and that's the one that then is used consistently for that individual. Gathering information from caregivers may be an important part. of completing tools, being consistent with the use of assessment tools, using the same tool under the same conditions. It's very important to be able to monitor change over time as a way to observe if behaviors that we think are pain-related are increasing or decreasing. As I mentioned, the PAIN-AD and the PAC-SLAC are recommended for routine use in the nursing home. And use of two tools together may provide a comprehensive approach, as we'll be discussing in the near future. Considerations in the use of nonverbal behavior tools are that behavior observation scores need to be considered in combination with what we've learned about existing painful conditions or diagnoses and what we're hearing from surrogates or proxies who know the patient. It's important to remember that some residents may not show obvious pain behaviors or cues, which is why it's really important to know what their normal pattern of behavior is to be able to look for more subtle atypical changes in behavior. It's important to understand that a behavioral pain score is not the same as a self-reported pain intensity score and cannot be compared directly to standard pain intensity ratings. So a tool that scored a 0 to 10 on pain behaviors is not the same as 0 to 10 on a numeric rating scale. These tools score increases and decreases in pain behavior, which are reflections of increases and decreases in pain, but not directly relatable to a numeric rating scale. The first tool is the PAIN-AD. And this is a tool that was developed to assess pain in persons with dementia. And it might be useful for use on a daily or as-needed basis. It's simple to understand and appears easy to use with limited training. Can be used by CNAs to help screen for pain on a regular basis. This slide illustrates the tool, and you'll see there's 5 categories of behavior: breathing, negative vocalization, facial expression, body language, and consolability. And each category of behavior is rated as 0, 1, or 2. And you'll see that as you move across the tool, the behaviors increase in intensity, suggesting higher levels of discomfort or pain. So what's the best way to use the PAIN-AD? It should be used to observe the resident both at rest and during activity. For each item on the tool, again, select the score 1, 2, 0, 1, or 2 that reflects the current state of the resident's behavior. Add the score for each item to achieve a total, and then compare that score after each use to the previous score received. Interpreting the PAIN-AD score is relatively simple. Looking at increases or decreases in the numbers of behaviors or the intensity of those behaviors suggests that pain is increasing or decreasing, or more severe or less severe. So it's a very helpful way with a few key behaviors to monitor and track changes in behavior over time. It's very important that screens or assessments using pain behavior tools get documented in a place that's accessible to other healthcare providers. We need the whole team to be using the same tools and using them the same way to be able to monitor for change over time. It's important for the nursing home to establish a procedure or a process for communicating scores, where this information is going to be documented, who's going to document it, who's going to monitor it for changes, to be able to do a good job of following up with what's happening with your resident's potential pain problem. The second tool is the PAC-SLAC, as I mentioned. This is a more comprehensive tool that includes not just observable behaviors that you can observe in a direct interaction, but also gather information on changes in behavior that might be occurring. It's relatively quick to complete, even though it does have 60 items, but once familiar with the tool, users say that you can move through it very quickly. It might be a better tool for a more comprehensive screening on a monthly or quarterly basis to identify resident-specific behaviors related to pain. It aligns well with the MDS 3.0 pain criteria as well, which can be helpful in completing those evaluations. The PAC-SLAC has a number of indicators, as I mentioned. They help to identify more atypical, individualized behaviors that might be pain-related. Rather than scoring on level of severity, this tool is just, are these behaviors present or absent, which does make it easier to use. There's 4 subscales, one focused on facial expressions, one activity and body movement, social and personality changes, and physiological indicators, appetite, sleep. As you can see on this slide, the examples of behaviors that are included, and you can see that this is much more comprehensive than those listed in the pain ad. So it's a nice complement to the other tool. The PAC-SLAC should be completed based on observations of the resident at rest and during activity. If observed only at rest, behaviors will be missed that might be pain-related. It's important to determine whether or not behaviors are present or absent, and then just total the tool of those that are present to determine the score. To interpret the score, we just compare the total after each use to the previous score received. As with the pain ad, an increased score indicates that there's an increase in pain, likely, and a lower score indicates that pain is likely to have decreased. We say likely because when you're using behaviors to identify potential pain, we know that behaviors can occur for many different reasons, and we're suspicious of pain when we see the behaviors that are on the PAC-SLAC, but it doesn't guarantee that pain is the cause. So once we have identified pain-related behaviors, it's important to do a thorough assessment and evaluation to try to validate if pain is the cause of those behaviors. And that may lead to the analgesic trial identified earlier as a way to test if indeed the behaviors you're seeing are related to pain, or if there may be another cause that needs to be followed up on. The takeaway message from this module is that pain assessments should be completed regularly. It's important to follow the typical procedure of screening for pain at admission, anytime there's a change in status, anytime pain is suspected, or at least quarterly. It's important to use a pain tool that's appropriate for your resident. Some may be able to use self-report tools. Others will require a reliance on observation of behaviors using a pain behavior tool. Documenting findings with each assessment is essential, and the nursing home should develop policies and procedures about how to screen, using what tools, where to document those assessments, and who's going to monitor them and follow up to assure that pain is identified and tracked. As the nurse, you are the leader in ensuring quality pain assessment for your residents. The use of best practices will assure that your residents' pain is recognized so treatment can follow and they can achieve the maximum quality of life, which is our ultimate goal.